For the next session, I would like to invite Dr. Vijay Shetty and Dr. Chintan Hegde. Hi, Chintan. How are you? Right. So, over to Chintan.
A very good evening to everyone. I'm Dr. Hegde. We have come to the penultimate session, I think, of this WIROC MAX 2022. And without wasting much time, I would like to invite our chairpersons, Dr. Salim Patel and Dr. Bakul Arora. Ajao. Please take your seats on the dais. Our session is on Ortho Biologics, and I get warm regards from my boss, my mentor, Dr. Vijay Shetty. He unfortunately had some prior commitments, so he couldn't come here. So let's get on with the session. We'll be talking initially about just basics on PRP and BMAC. And then we have great interesting lectures from Dr. Chirag. Dr. Manan is going to do a literature review. And we have Dr. Sandeep also with us, who's going to speak on avascular necrosis. So the first introductory talk I would like to start. Let's talk on role of PRP in orthopedics. So PRP, as a fellow, as a junior, I got introduced to it by my boss, Dr. Vijay Shetty, and we started working on this. And it came to fame basically when these two great sports personalities from the Pittsburgh Steelers, they used their own blood. That was a line which was used in the New York Times, where they used their own blood to get treated for their ligament injuries. So as we know, the healing response is by the injured tissue. There's inflammation initially, and then there's tissue remodeling, and then the wound heals. So the healing response can lead to scar tissues, can give us a partial function, or can sometimes give a fully functional outcome. So that's where the growth factors help us in helping such patients who have recovered partially and want to attain maximum recovery. So the platelets help us in coagulation and tissue healing. And there are various growth factors which are associated with the platelets. That's the TGF-beta. We have the basic fibroblast growth factors. We have the platelet-derived growth factors, A and B. We have the epidermal growth factor. Then we have the vascular endothelial growth factors and the connective tissue growth factors. So a normal count, as we know that it's around 2 into 10 is to the power of 5 per microliters. But a PRP is considered PRP when it is at least 4 times or greater above the baselines. And the science behind this platelet-rich plasma, PRP, is that when the platelet concentration is 5 times more, there is activation of the thrombin, calcium, and soluble collagen. There's a release of growth factors, and these growth factors help us in forming a scaffold, and that causes stem cells migration and differentiation, and then which finally forms like a biological glue. Now, platelet-rich plasma biology, firstly, the growth factors, which are the PDGF growth factors, they initiate connective tissue healing. They help in mitogenesis. They help in differentiation of fibroblasts. The epidermal growth factors also help in epithelial development. They promote angiogenesis. The vascular ones also help in angiogenetic properties. And the growth factors also help in chemotaxis and mitogenesis. Now, as we know, the mechanism of action, the initial tissue response is there's clotting, and then there's inflammation, which causes removal of the debris, and then there's newborn formation in the form of tissue regeneration. So the chemoattraction and mitosis is the principle what PRP uses, and initially there's fibrin mesh formation, then there's a growth factor release, then we have chemotaxis and chemoattraction, then we have proliferation, and then finally differentiation. So PRP, considering all these properties, all these biochemistry or microbiological properties, what I've just mentioned, in simple words, as we can see down, it's got antibacterial effect, it's got an analgesic effect, and finally an anti-inflammatory effect. Initially, we started using this harvest machines for developing PRPs in our institute, and we were one of the first teams in India to get a paper published. We compared it with the corticosteroid versus PRP in plantar fasciitis, and we had great positive results, and we actually published that paper. And so an exponentially increase in the undifferentiated cell proliferation occurs as the platelet concentration increases 2.5 to 5 times or 10 times above the baseline. Currently we use it on plantar fasciitis. I regularly use it in my practice. We give it under ultrasound guided guidance. There are a lot of papers which are published now for plantar fasciitis, which has shown that PRP injections definitely are giving better and more long-term results from pain relief. Tennis elbow is one other pathology where PRP is working very well in our hand. I would like to also give credit to this man here, Mr. Dr. Alan Mishra. He in touch with our head of the department. We got that idea of starting PRP in our institute, and he was one of the pioneers who started it for tennis elbows. And this was his initial paper in 2006, which showed fantastic results for chronic elbow tendinosis. PRP has also shown positive results in muscle injuries, which has shown quicker return in play. And also compared to other therapies, PRP has shown better functional outcomes in Achilles tendon injuries. We have sports people recovering from grade 2 MCL injuries or partial ACL injuries with the help of PRP therapy. So PRP is slowly expanding its indications, and we are still on the learning curve, but I definitely see a very positive future for PRP. And finally, PRP breaks this cycle of this vicious cycle of no inflammatory response, repetitive injury, and then hypovascularity. So PRP breaks this vicious cycle and tries to create more vascularity and better healed tissues. So the few other indications are rotator cuff tears and degenerative cartilage lesions also. Other users include jumpers knees, wound healing in TKR, fractures, not delayed unions, slab lesions, meniscal repairs, and osteochondritis dissecans. Currently we use Trisel, and this is showing more better concentrate of platelets and significantly better results as compared to the previous ones. So platelet concentrates mainly depend on what machine you're using. You have to be thorough with your machines, and you should know what kind of platelet concentrations you are going to achieve. So on concluding it, it's an autologous, it negates any risk of infection, it's free of side effects, it's cost effective, the costs have tremendously come down, and it's an emerging regenerative tool. Yeah. Thank you. I would request the next speaker to take over. Dr. Chirag.
Let him come.
Okay. Okay. So we have Dr. Vijay Shetty's fellow just going to speak about their current work which has been happening in Hiranani Hospital. So over to you.
Thank you, sir. Good evening to one and all. So I'll be speaking on the use of PRP in osteoarthritis knee. So coming to osteoarthritis, the treatment spectrum. So ranging from grade 1 to grade 4, we have multiple options available, from medications, physiotherapy, injections, arthroscopy, and the last one, that is joint replacement. So I'll be covering the injection part. So the options available are steroids, viscosupplementation, and platelet-rich plasma. So why PRP? So let me reframe the question, why not PRP? So when you always start a new therapy, the points to consider are safety, efficacy, evidence, recommendations from regulating body, and the cost. So if you do PRP in osteoarthritis, a literature search, so from 1975 to 2020, you can see in the initial stages, there was no use of PRP. In 2010, literature search showed 8 searches, whereas in 2019, it increased to 127. So coming to the growth factors in osteoarthritis, or the safety of the growth factors. So this was a study conducted in Spain on the intra-articular injection of an autologous preparation rich in growth factors for the treatment of knee OA. So the conclusion was that although these preliminary results needed to be evaluated in a randomized clinical trial, they provide useful information about the safety of growth factors and open new perspectives on autologous treatment for joint disease. Another paper which was conducted in Italy on the platelet-rich plasma of intra-articular knee injections. So they were of the conclusion that there was significant improvement at 1 year. However, this had the potential to reduce pain and improve knee function and quality of lives in younger patients with low degree of articular degeneration. Another study conducted at the Ortho Biologics Institute in Los Angeles in USA concluded that there was no adverse effects. However, the positive trends and safety profile demonstrated could potentially be used to inspire a larger blinded and randomized clinical trial to determine whether platelet-rich plasma is safe and effective for the treatment of knee osteoarthritis. Now, coming to the effective part, so there was a study conducted in Italy on the comparison between hyaluronic acid and platelet-rich plasma. So the conclusion was that even in grade 3 osteoarthritis knee, the treatment with platelet plasma showed a significant better clinical outcome than the treatment with hyaluronic acid, with sustained lower WOMAC scores. Treatment with hyaluronic acid did not seem to be effective in the patients with grade 3. What about evidence? So I'll come to the ortho evidence part. So ortho evidence in August 2018, 16 randomized controlled trials evaluated the use of PRP in the management of knee osteoarthritis. So when you compare PRP versus placebo at 3 months and at 12 months, PRP was found to be effective. Similarly, at 12 months, PRP was found to be effective as compared to a placebo. Now, what about PRP versus non-operative management or physiotherapy? PRP was again found to be effective at 3 months, whereas at 12 months, there was no difference between the use of PRP and non-operative management. What about PRP versus steroids? Definitely PRP was found to be more effective than steroids at 3 months. And PRP versus hyaluronic acid, it was found to be equal at 3 months and more effective than hyaluronic acid at 12 months. So there was a systemic review and meta-analysis of randomized controlled trials, which was conducted by John Belk. So it was a level 1 study of 18 randomized controlled trials with the mean follow-up being 11 months. So the PRP group did significantly better in terms of the visual analog scale, the WOMAC score, and the International Knee Documentation Committee score. And leukocyte poor PRP had a superior performance as compared to a leukocyte rich PRP. So the National Institute for Health and Care Excellence recommended in 2019 that the safety of PRP had no major concerns and the efficacy was limited in quality. However, the recommendations were to be used with fully informed consent. So PRP in OA is safe, efficacy is proved, there is evidence, and it's recommended. So the conclusion is there is no harm in using PRP in osteoarthritis knee. However, careful assessment of the patient should be done. It should be used with an informed consent, and leukocyte poor PRP should be preferred in osteoarthritis. Thank you.
Can I have the next speaker now? Dr. Chirag, who will be talking on GFC in the treatment of osteoarthritis.
Next. Hi, good evening everyone. I would be talking on growth factor concentrate in knee osteoarthritis. As very well spoken by previous speakers, that PRP has been very useful in treatments of orthopedic injuries and osteoarthritis. It is prepared using a double spin method where there is a first spin and a second spin. But what we also know is increase in platelet concentration does not mean there are more number of platelets. In PRP, about 20 to 30% loss of platelets are seen in the final PRP outcome when compared to the whole sample of the blood. Okay, and also the second spin, which is a highly concentrated spin which gives a high concentration of platelets, they also cause alteration in the platelet morphology. Also, the final outcome is only 0.5 to 1.5 ml of PRP, which is not adequate and which has to be diluted with a platelet poor plasma. And also that we don't know about PRP is how exactly the platelets are activated inside, how many platelets are activated, and how many growth factors are released. Okay? Even though literature does show good response of PRP, it has shown to reduce the pain and improve the functional status in osteoarthritis. There are also studies which says that there's more pain relief as compared to HA injection. But there's also a study which says there is a call for standardization in the PRP preparation protocols and composition reporting. They did not provide sufficient information to allow the protocol to be reproduced. Okay? So there are a few challenges and unmet needs with PRP. There are no standardized protocol. The final output is insufficient at times. There is no growth factor quantification. There are conflicting results. There is post-procedural pain and inflammation because of the RBCs and the WBCs. The process is complex, and there is a high operator-dependent variation. So to tackle these challenges, we have introduced OsteoNext, which is India's first ready-to-inject autologous growth factor concentrate therapy. So this is the kit, which the OsteoNext kit, and they provide a lot of stuff inside. And the final preparation looks something like this, where there is a GFC, 2 ml of GFC layer on the top, and all the cellular component is in the base. So what are the advantages that we get with GFC therapy? It is pure and ready to inject. It is all autologous. It is completely acellular, so no inflammation. There is in vitro activation of the platelet by Vokat's platelet activation solution, and there is a minimal operator-dependent variation. So most of the challenges of PRP are met over here. Okay, the possible side effects, since they do not have any RBCs or WBCs, so there is no chance of inflammation. The contraindication being active infection, patient with bleeding disorders, heavy smokers, uncontrolled diabetes, malignancies, these patients are not taken up for PRP injections. So OsteoNext kit will definitely provide an acellular GFC. It is sterile. The GFC is very stable. You can keep it at room temperature for 8 hours and at 4 degrees for 1 week. Okay, so these are the benefits of GFC over PRP. Both are prepared from patient's blood, but the final outcome has only a high concentration of growth factors as compared to platelets with some unwanted cells in PRP. Okay, here in PRP, the centrifugation is the first step of the PRP preparation, where in growth factor concentrate, first the platelets are activated, the growth factors are released, and then the centrifugation happens. So there is no platelet loss. I'll just like to extend a little bit, if you allow. It's again a very, very easy process. It's a very sterile process. The GFC is stable, okay, and less injections are required as compared to PRP, and there is very, very less chances of inflammation. We did conduct a study to compare the efficacy and safety of GFC as compared to HA injection. It was published. It was a multi-centric trial, a randomized prospective trial. And we gave 3 doses of GFC at monthly interval, and we compared it with 3 doses of HA injection, and the patients were followed up to 11 months. The outcome parameters were measured by the VAS scores, WOMAC scores, KOOS, and IKDC scores. So the inclusion criteria of grade 2 and grade 3 osteoarthritis with pain score of more than 4 even after taking NSAIDs for more than 2 weeks. And they were randomly distributed in HA and growth factor studies. Advanced osteoarthritis grade 4 were excluded. Patient with knee instability and previous knee surgeries were excluded. Systemic inflammatory arthritis patients were excluded. And patients who had taken an intra-articular corticosteroid injection in last 30 days were not taken up in the inclusion criteria. Okay, how is it prepared? 4 ml of blood is all that is required. It is been collected into a GFC tube or a vacutainer which contains the Vokat's patented platelet activation solution. We just have to mix it with the solution for 8 to 10. We have to invert it for 8 to 10 times and keep it to rest for 30 minutes. In that 30 minutes, the activation of the platelet happens and the growth factors are released. Then you centrifuge it at 3,400 RPM for 10 minutes. All the cellular components settles down. There is a nice gel layer between the growth factor and the cells, so there's no contamination of the unwanted cells in the GFC. All you have to do is invert the tube, collect the GFC. You have 2 ml of GFC in 4 ml of blood, and that is ready to inject. Okay. The primary endpoint of the study was to see the change in baseline WOMAC score at 11 months. The secondary efficacy endpoints were a change in VAS score, WOMAC score, KOOS scores at 5, 8, and 11 months. Coming to the results, the primary endpoint result at 11 months of WOMAC score, there was a significant improvement seen with AGFC, which was statistically significant. At secondary endpoint, at 8 months and 11th month, also statistically significant improvement. the visual analog score changed from baseline at 1, 2, 5, 8, and 11 months was also statistically significant. Even the WOMAC, KOOS, and IKDC scale, there was a change in baseline at 5 months, 8 months, and 11 months, which were also statistically significant. So to conclude, at 11 months, there was a greater improvement seen with Osinex AGFC injection as compared to HA group. It was better than HA injection in terms of pain relief and function. It shows statistically significant improvement before treatment to after treatment in the WOMAC, KOOS, IKDC, and VAS scales. And it was safe, effective, and well tolerated by the patients. The other indications for growth factor concentrate is where you all use PRP is tennis elbow, plantar fasciitis, acute ligament muscle injuries, hip and ankle osteoarthritis, shoulder pain, tendinitis, tendinosis in elbow, hip, shoulder, knee, etc. Okay, so the take-home message is growth factor concentrate is there to stay. It is non-surgical process. There is no platelet loss. There is a high concentration of growth factors present, completely acellular, so reduces the risk of pain and inflammation. It has an excellent stability. It is a safe option. There is no risk of contamination and a simple protocol with minimal operator-dependent variation. Thank you.
We can have the next speaker, that is Dr. Sandeep Gavhale for AV and hip in BMAC and PRP.
Good evening, everyone. I'll be speaking on BMAC and PRP in hip AVN. So, we all know the stages of the hip arthritis. So, in which stage we should use this BMAC or PRP? So, Ficus stages 1 and 2 are the stages in which we can use this BMAC or PRP. And good to excellent results have been reported when combined the core decompression with BMAC or PRP or both. So what is BMAC? BMAC or bone marrow aspiration concentrate. It contains mesenchymal stem cells, growth factors, anti-inflammatory factors, etc. The mesenchymal stem cells are multipotent stem cells and have immunomodulatory, anti-inflammatory, and anti-apoptosis actions. And how to prepare this BMAC? The approximately 60 ml of bone marrow aspirate is collected for processing from PSIS or ASIS. PSIS is preferred over the ASIS, and double centrifugation method is used, followed by cold preconditioning at 4 degrees Celsius and LED light bath for 20 minutes. It is the recommended procedure for preparing the BMAC. The mechanism of action of the BMAC. The BMAC contains mesenchymal stem cells. So it has 4 actions. The mesenchymal stem cell, it itself, it's a multipotent cell, and it differentiates into chondrocyte, osteocyte, and adipocytes. Also, the cell has a self-renewal capacity, and also it has a immunomodulatory action. And this is how the mesenchymal stem cells, they act in the case of osteonecrosis of the femoral head. So this is a recent study. They studied the role of cell therapy in osteonecrosis of the femoral head, and their interpretation was the mesenchymal stem cells, when we inject via the core decompression tract, particularly when employed at early pre-collapse stages, would improve the survivorship of femoral heads and reduce the need for hip arthroplasty. Again, PRP preparation, we have seen in the previous talks how to prepare it. The mechanism of action of PRP in osteonecrosis of the femoral head, it has many growth factors which induce the angiogenesis and osteogenesis. Also, it has interleukins and TNF-alpha and Rankel expressors which inhibit the inflammatory reaction at the osteonecrosis site. And also, it activates the AKT bad signal pathway and prevents the apoptosis induced by the glucocorticoids or any other agents which cause the osteonecrosis of the femoral head. So we have seen the PRP and BMAC. So now what if we add the PRP and BMAC? How will they act? How the synergy it will act? So the growth factor, cytokine and chemokine profiles seen in both PRP and BMAC, they vary in proportion. The combination of PRP with BMAC appears to mimic the natural cascade that occurs in fractured bone healing. The addition of PRP to BMAC has been shown to act as a rich and natural source of culture medium for mesenchymal stem cells in the bone marrow, and hence they work both synergistically to enhance the bone healing. These are few literature studies which indicates that when the PRP and BMAC are used simultaneously, the progression of osteonecrosis is only seen in 21% of the patients. These are various studies which have shown the synergy works very well as compared to PRP or BMAC alone. The procedure. So the entire procedure consists of core decompression, removing the cell debris, bone plug application, and injection of the preparation. So the guide pin insertion, we should start from the just few minutes at the base of the LT, and we should aim to reach the superior lateral portion in the femoral head in both AP and the lateral shoots. That guide wire is drilled with the 8 mm drill bit. Make sure you reach the subchondral area. We remove the debris with curettes. Make sure you remove the debris from the subchondral area or the desired this thing. How to prepare the bone graft as a plug? We use allograft for preparation of the bone graft. So we make a 8 mm diameter bone plug to put at the side of the drilling, and make a drill hole into center of that plug so that you can inject your aspiration, or you can pass your needle through that bone plug. So this is once we make that plug, we fix that plug here and pass our needle from that hole or the pre-drilled hole, and we put the concentrate here in this area. This is the post-procedure X-ray. Post-operative management, the exercises are started from the day 1. Partial weight bearing is permitted after 3 weeks with the use of crutches or walker for 3 weeks, and then full weight bearing. Analgesics, SOS, and thromboprophylaxis is given for first 3 weeks. So what are the advantages? It is minimally invasive, preserves patient's native joint. The patient's own bone marrow or blood is used to stimulate the biological healing. It is cost effective, can be performed as daycare or outpatient procedure, and the hip scores are improved significantly when combined with the core decompression alone. The disadvantages, it is not indicated in the later stages of AVN and not safe to perform without the aid of intraoperative imaging. So finally, the core decompression augmented with BMAC and PRP is effective in providing pain relief, improving the functional status, and delaying or cessation of progression in early stages of the hip AVN. Thank you so much.
Thank you. So we have the last speaker now, that is Dr. Manan Vora, and he's going to talk about the current literature review.
Hello. Yeah. Good evening. Firstly, thank you so much to Dr. Jayesh Gandhi, Dr. Ashish Vadnis sir, and Dr. Chintan sir for this opportunity. I'll be talking about PRP in sports injuries. The learning objectives today will be to review the current treatment options in partial ACL tears, plantar fasciitis, and tennis elbow, and to consider PRP as an alternative. We'll also understand the current literature review with regards to PRP in these conditions. So when it comes to partial ACL tears, this is a little gray area. Currently, we have conservative treatments with physiotherapy, partial reconstruction in terms of bundle augmentation, or complete ACL reconstruction according to the injured bundles. Currently, the preclinical studies have shown enough qualities of PRP. I'll just run through them because my previous speakers have elaborated on it helping the regulation of the articular environment, exerting a positive metabolic modulation on all joint tissues, and overall tissue healing promotion. It stimulates fibroblast proliferation, collagen fibers deposition, and reduces the catabolic distress when applied to ACL-derived tenocytes, which provide a better histological appearance and superior biomechanical properties. Now, I came across this very interesting study which was done to evaluate the midterm outcome of patients having partial ACL tears treated by intraligament injection of autologous conditioned plasma and healing response technique. And it was then according to both functional and clinical criteria. Now, this healing response technique, I found that very interesting. It was the trephinition of the fossa intercondylaris of the lateral femoral condyle next to the ACL insertion. Now, this resulted in an inflow of growth factors and mesenchymal stem cells out of the femoral condyle into the ACL defect site, stimulating tissue regeneration and scarring. Now, the inclusion criteria for this was patients were screened for partial ACL rupture, while partial ACL rupture was importantly defined as a partial rupture of the anteromedial or the posterolateral or partial rupture of both ACL bundles. The interesting part about this study was that everyone was screened with a diagnostic arthroscopy, which may not be the case in each and every patient in other studies. And then an intraligament ACP application was done into the distal ACL stump. I've made an entire slide on the post-op rehabilitation because this was a major reason for the success of this study. So as you can see, the index knee was immobilized in a flex splint and partial load bearing was followed for 1 to 2 weeks. During this period, there was passive range of motion 0 to 60 by a trained physiotherapist. Full extension was avoided to reduce the tension on the ACL during the initial period. In the 3rd week, it was then when the full weight bearing was started. For additional external stabilization, an ACL brace with a limited range of motion during the day and a 20-degree flexed immobilizing splint was applied overnight. Proprioception was then trained by the physiotherapist, and after 6 weeks of training intensity, later on, active muscle strengthening has been started. Now the results, there were 42 patients and there was a mean follow-up of 33 months. There was a satisfactory outcome after this entire process with just a 9.5% failure rate and a high percentage of return to sport activity, almost 86%. The quantity and quality of the movement was tested with drop jump, side hop, quick feet, and 1 to 2 leg stability tests. All of these tests showed a promising result in all included patients. So the points to note were that this technique enables the patients to return to sport after a shorter rehabilitation period. The training was started with a mean period of 12 weeks and a pre-injury level of sport activity and a mean of 5 months in 71% of the patients. Grade 1 and 2 ACLs returned at 9 weeks and at sporting activity at around 5 months. And these results then correlate with previously published literature when it comes to PRP for partial ACLs. I'm running out of time, but I'll quickly run through plantar fasciitis and tennis elbow. These are the current options. I'm sure you're aware of them. With the current verdict on steroids, a lot of orthopedicians are still using steroids, is that they are effective in the short term, but as Dr. Chintan also mentioned, in the long term, PRP seems to be a better option. This was a very good study that I came across that had a meta-analysis of 10 randomized controlled trials, and these were the results, that PRP was effective at reducing pain and improving physical function. However, a subgroup analysis demonstrated that 12 months of long-term PRP could improve pain and physical function, but 1 to 6 months of short-term PRP probably could not. Long-term effects showed better VAS, AOFAS, and RMS scores, and the difference was definitely clinically significant at the 12 to 24-month follow-ups. I'll be done in a minute, please. The conclusion is that PRP was as effective as other treatments in terms of pain and functional results in the treatment of patients with plantar fasciitis in the long term, but in the short term, probably not. Moving on to tennis elbow, once again, you're aware of the current treatment options. We're all dealing with them. Nearly 85 to 95% of them get complete relief at the 1-year follow-up, but for those who don't, PRP definitely can be considered. There was shockwave therapy, some of you may have heard of it, that really came in at one point, but a massive systemic review has shown that it provides no significant long-term benefit. Once again, PRP, like my previous speakers have spoken, I'll run through this because PRP in tennis elbow, there's enough talk about it and its benefits in providing pain relief over time. And moving on, I wanted to talk about this one, which actually compared PRP to surgery. The aim of this study was to compare the outcomes of PRP injections to surgical release and decortication for lateral elbow tendinosis within a similar patient population. And this was once again the rehab. I'm again emphasizing on it because that is a big point in the success of the procedure. Stretching protocols were initiated 48 hours after. Patients were restricted from lifting more than 20 pounds until the 2nd week. Repetitive activities were recommended were avoided until 6 weeks, and sports was restricted for 3 months. This was the surgical release that was done. And just to show you the pain, percent of pain reduction, symptom improvement, tenderness, pain, full elbow range of motion, return to activity, all of this, there were similar outcomes between PRP for tennis elbow versus surgery. So similar outcomes and return to work can be achievable with PRP as well as with surgery. Your take-home message is that the patient selection is of utmost importance. Post-procedure rehabilitation plays a key role. If conservative methods fail, PRP must be considered as there is no major side effect or complication. And while a lot of studies promote the use of PRP, more research and evidence is still needed going forward. Thank you so much.
Thank you, Dr. Manan. Good talk. Anybody has any questions for any of our speakers? We have 2 minutes. We can take the questions in case there are any. So I think we should call it off with the session, and I can ask all the speakers to come in for a photograph, and wish everybody a very happy new year in advance.